Good afternoon, everyone, and a very warm welcome to the third edition of Breast Cancer Action Month 2022. I am Dr. Nalini Kaushik, Policy and Advocacy Lead at the Integrated Health and Wellbeing Council, India's premier institution for health awareness, advocacy, and behavior change. At ISW Council, we have been relentlessly working on creating awareness around the critical issues of health and well-being. So many of us must be already aware that every year the month of October is observed as Breast Cancer Awareness Month, which is dedicated to create awareness on cancer as a public health issue and to strengthen actions towards improving access to quality care, screening, early detection, treatment, and palliative care. ISW Council instituted Breast Cancer Action Day for October 21st to motivate people to act against breast cancer with a simple home based screening routine and to change a negative outlook towards it while ensuring relevant awareness. The day is also a reminder to the policymakers and the healthcare providers to build a good environment and infrastructure for early detection and effective treatment of the disease. So, therefore, before we set into motion the third Breast Cancer Action Day, we would like to play out a short video of the past sessions and how the movement is getting stronger and more impactful with each passing year.
As breast cancer is the number one type of cancer in women today.
मुझे आज ब्रेस्ट कैंसर एक्शन डे से उम्मीद है कि जागरूकता और उपायों के बारे में लोगों को बताकर हम देश में ज्यादा लोगों के बीच कैंसर होने से रोक सकते हैं.
I'm confident that the contribution of the Integrated Health and Wellbeing Council will certainly help in checking and treating cancer.
That this is preventable, provided we feel ourselves on a daily basis. We love our bodies, we value them and take care of them.
The problem is really at two levels. One is with the media centering a lot of communication around what is significant in that month. And the second is, as a society itself, we just don't want to mention the word breast.
We have to create a complete ecosystem which can really help early detection, early treatment, and help patients live a longer and healthier life.
The most important thing is to be aware of the risk of, that you're a female, you can get breast cancer.
We need a multidisciplinary approach to tackle this menace. We need to have a multi-pronged strategy comprising awareness programs, need to take preventive action.
Amongst all, as per the ICMR, recognize that the most deadly one is the breast cancer.
We must channelize them towards adopting a healthy lifestyle that will reduce the risk of cancer.
If our female students become aware from the very beginning of the life, then the chances of breast cancer will be reduced considerably.
You should live each day as it comes, and then you aspire to inspire before you expire.
I see a lot of hope in CSR. Corporates can have a cancer fund for their employees. Why not?
Basically bring the funding agencies together and to channelize, harmonize, and prioritize cancer research in India.
Make the education better for consumers, but also the education has to evolve for the medical professionals, the nurses, the health staff, and all of that. Put the budget together. How do you find someone to be able to fund all of this?
There must be teamwork or integrated approach of breast cancer management.
It's really about driving education, sharing the latest information, and building a platform to allow exchange of different ideas.
Thank you. So here were the glimpses of what we have done in the past, and moving forward, we look forward to having this great panel discussion. So now, if we look at the World Health Organization data from 2020, more than 2 million women were diagnosed with breast cancer, and nearly 0.7 million deaths were reported globally. In India itself, the incidence has increased significantly, almost by 50%. And in terms of mortality, 37.2% of women died from this disease in India in 2020, making these figures higher than the Asian rate of 34%. Moving forward, our inaugural session about overcoming disparities in breast cancer and management will analyze gaps in breast cancer care and treatment. To begin the same, let us hear from Dr. Mahendra Manjapara, Honorable Minister of State for Ayush and the Minister of State for Women and Child Development, Government of India.
Namaste. At the outset, I would like to congratulate the Integrated Health and Wellbeing Council for organizing the third edition of Breast Cancer Action Month under Rapid Global Cancer Alliance initiative of collaborating with stakeholders across the cancer community to advocate for policies that will decrease the global cancer burden. I am sure the initiative will act as a knowledge sharing platform for the key stakeholders, experts, and thought leaders from relevant sectors to come together and analyze the gaps in the cancer ecosystem and address the different challenges that could serve as the basis for concerted improvement in lives of patients with breast cancer in India. At the same time, I also urge the medical fraternity to expand the treatment of breast cancer to the remotest of the areas. We need to prioritize the health and lives of our women with better diagnostic and treatment facilities. Ayushman Bharat has helped women in rural and remote area improve their health drastically. Now with the Ayushman Bharat Digital Mission, we are working on a mission to expand the reach of healthcare service for breast cancer as well as all other major diseases to remotest corner of India in next few years. As we move forward, I am hopeful that with the Breast Cancer Action Day, we can look forward to seeing awareness and willingness to detect and defeat the spread of cancer far and wide. My best wishes to this effort of the IHW Council for this timely initiative. The coming years will surely see future breast cancer care more competent and patient-centric, and awareness initiatives like will prove the game changer in this regard. Thank you. Jai Hind. Jai Hind.
Thank you so much, sir, for your important remarks. So moving forward, we begin the inaugural panel discussion, and we have a very stellar panel with us, some, like critical people who have shaped the cancer care in India at the center level and at the state level. We have with us Dr. G.K. Rath. He is the head of National Cancer Institute and a professor of radiation oncology, AIIMS, New Delhi. Dr. Madan Gopal, he's a senior consultant of health at Niti Aayog, Government of India. Dr. Hira Lal, IAS, Additional Health Mission Director, Government of Uttar Pradesh. And Dr. Arindam, who's an oncologist and currently representing Atal Bihari Regional Cancer Center, Agartala, Tripura. Thank you so much to all of you for joining us. Dr. Rath, thank you so much. Despite your busy schedule, thank you so much for being here today with us. If you could just switch on your camera, we would like to begin the discussion with you today. Dr. Rath, sir, can we have you on the camera? Hello, good afternoon, sir.
Good afternoon. Good afternoon. Can I say my opening remarks?
Absolutely, sir. Absolutely.
Thank you very much. This is a very important meeting because breast cancer today is the, number one cancer, not only ladies, but in both sexes. If you take both sexes together, breast cancer is number one, not only in India, but in the world also. Another most important factor is, which is our own data. I head the Scientific Advisory Committee of ICMR of National Cancer Research Program. If you see our last 40 years data, then you will see something consistent, which we have to do. Number one is that breast cancer is not a preventable disease, unlike oral cancer and cervical cancer. Very difficult thing to die, but that's it. Then our main emphasis is on early diagnosis because we can prevent it. Number two, it is predominantly a urban disease. And please note my sayings. Since last 40 years, our finding has been breast cancer incidence is 9 per 1 lakh in a place called Barsi. It's a village in Maharashtra. Barsi, 9 per 100,000. In Delhi and Hyderabad, it is 40 per 100,000. In US, it is 110 per 1 lakh. What does it mean? It is a predominantly urban-oriented disease. So we have to see that, not that we send people to villages, but just to know it. And the factors everybody knows: late age of marriage, late age of having a first child, and late age of not breastfeeding, like that. So what should we do? I think what the efforts which IHW is doing is consciousness and awareness among our ladies to see that after the age of 45, everybody must get a mammogram. Number one. Number two, if there is a family history, because 15% people have family history, then one could do a imaging, not mammogram. They should start ultrasound or MRI from the age of 30. That's number two. Number three, we must have a breast cancer awareness program for everybody in this country so that people should know. Because that's another fact. I'm just telling you the facts which are there in our, if you go to the website of NCRP, it's all there. Stage 1 cure rate is 95%. 95% cure rate, unlike pancreas, which is any stage cure rate is 6%. So it's a very good cure rate. So our main emphasis should be early diagnosis. But of course, stage 4, the cure rate drops down to 30%, 40%. So these are the 3-4 things on which we should concentrate our efforts. If there is any other question, I'll answer that. Thank you very much.
Thank you so much, sir. Thank you so much for your valuable remarks. And yes, definitely there are few more questions, and your presence is, of a lot of significance for us today. So I'll just come back to you with within these another round of questions. Thank you so much, sir. Today we also have with us representatives who play a very significant role in formulating and shaping the policies in India. So we have Dr. Madan, who is representing Niti Aayog, and we also have Dr. Hiralal representing the state level health department. So I think we're going to start with the central level and see that how the entire breast cancer care scenario is accordingly being shaped at the state level as well. So, Dr. Madan, can we have you here with us?
Thank you.
Thank you so much, sir, for joining us today.
At least I could make it on time.
Absolutely, absolutely. Okay. Thank you so much, sir.
One of the important things, as Dr. Rath has pointed out, that this breast cancer, it has now become the #1 cancer.
Yeah.
But major important factor is the screening for breast cancer. There's a major challenge. How to make the people aware, how this screening can happen, and what devices are available, and how to make this device more accessible and affordable. These are the 3 things where we need to focus on. So regarding raising awareness, if you look at right from the school health program which we are having, we have to start focusing from that area to make the people aware how to examine the breast from that level. We have to start from that level. And in the rural sector, as they have to know that how to examine their breast in case of any unusual presence felt in their breast. They should immediately seek medical attention as well as go for some diagnostic test and the procedures. That should be there. But how much it is happening? We have created a structure of health institutions. The health focus has been predominantly in the rural sector. We have built in the utilization of the public and the private sector is more or less now equal, so 45 to 55%. That's the range is there. right up to the 5,000, 3,000 population, depending on the difficulty of terrain, we are having health and wellness center. One of the important component of health and wellness center is population-based screening for cancers. But that component is yet to be operationalized in many of the centers. But that is very much in the line that how to increase the screening so that early detection happens and the person is put on treatment as early as possible. That's one thing. Second thing is how to make the diagnostic facilities for detecting the lump mass and doing a mammograph and other facilities which are required at this next level. So we have to see that how we progress in that direction. The third is after detecting, diagnosing, do we have adequate beds for providing treatment as well as providing surgical care, providing chemotherapy. And the chemotherapy is another area where we see that how if the person is diagnosed at the apex level, after the diagnosis happens at the apex level and the cancer board provides a line of treatment, whether that kind of treatment can be executed at the lower level so that the visit to the facility is reduced and the catastrophe due to this cancer event is reduced on the patient as well as in the family. We said, see that how we do that thing, that's the biggest challenge. I will stop here. I will take further questions as we
Right. Thank you so much, sir, for your remarks. But also, just to follow up, what Dr. Rathan has said, and just coming back to you, that we see that a lot of health system programs are being designed by the government as well. But when we look at the urban-rural divide here, when it comes to the incidence of breast cancer, and since more cases are concentrated in the urban areas, are there certain measures that government is sort of planning, and is government cognizant of doing something on those lines?
Yes, in the urban areas also things are moving slowly, but they are moving. In the urban areas, although the similar structure is trying to be replicated, that means we do have urban PSCs and urban health and wellness centers.
Right.
So health and wellness center is more or less would be providing extension of services in which population-based screening would be an integral part of that. That it is in work, it's in progress. We had a urban health mission since 2013, which was subsequently subsumed into the health mission. But nevertheless, focus is in the urban areas as well. But the bottom line is how to make people aware that if something goes wrong, how to examine that thing, how to take the things to the next level if some abnormality is detected, then whether the facilities are made available. That kind of models needs to evolve. Because having treatment centers for cancer is not the answer, because how many cancer beds and how many cancer hospitals you can create.
Absolutely.
Instead of that, if we focus more on the preventive aspect so that the early detection happens, the progression is fast, and the person, even if the person is put on treatment, surgical treatment, chemotherapy or radiation treatment, whether that can be done at a lower centers with the hub and spoke kind of thing, that kind of models needs to evolve. Otherwise, just focusing on the curative aspect, we would be draining our resources. But the more emphasis should be on the preventive aspect for prevention of this cancer, as well as promotion of the practices for examination and the other things.
Absolutely, sir. And I think, completely agree with you on that. And I think for breast cancer, like we say, early screening is paramount. So, I think that has to be, the focus at all the health systems level. And on that, I will move to Dr. Hira Lal. He is representing, government of Uttar Pradesh. And so again, just circling back, what we have been discussing today, early screening and early diagnosis are paramount when it comes to breast cancer. So what specific measures are being taken place in the state of Uttar Pradesh when it comes to breast cancer?
Okay, actually I have been given a note and data which is very alarming, which I would like to share it, that every 4 minutes one woman is detected with the breast cancer. Every 13 minutes one woman is dying with the breast cancer, and by 2030 the breast cancer death will be the highest among all the disorders in the women. So that is very alarming situation which we have already reached. So the and major reason of the death is late detection and late diagnosis. So problem statement is late detection and late diagnosis. Here we have to find the solution how to remove this late detection, late diagnosis with the early detection and early diagnosis. And that is only way to aware the concerned masses. In awareing the concerned masses, there are many things. For noticing early symptoms, if people will know, they will be knowing what are the symptoms. Then if they will get any symptom, then they will approach for the diagnosis and detection, and early detection will be in the picture. Likewise, lifestyle is a major cause in not only breast cancer, but in all the ailments. Obesity and lifestyle, late sleeping, fooding habits, junk foods. So preventive lifestyle awareness is another area where we need to work more, and dispelling myths and misinformation about this disorder. So if we work on these three to aware the masses, now question is who is the target for this? That is the women. So schools, whether it is a primary level school from 1 to 8 or middle 9 to 12th or higher education, there are women's institutions imparting education. So we can catch them, we can go there, and we can aware them on these three things. If we will do that, so the prevention is better than cure. Our prevention part will be more strong. If prevention part will be more strong, then cure is required less. In detection, after detection, we required rapid treatment. Rapid treatment means adequate treatment, timely treatment, and affordable treatment. If let us suppose disease is detected, breast cancer is detected, and if it is not affordable, timely treatment is not given, and if treatment is not adequate, then even after detection, we are not serving our purpose. As Dr. Rath told that cure rate is more than 95% at stage 1 detection, meaning thereby if we are detecting early, our cure, the pressure on cure system will be automatically removed. So my request and my suggestion is that in this case, we should focus more on prevention rather than cure. It doesn't mean we are ignoring the cure.
Yes.
Cure is there, but more focus we should do on the prevention.
Absolutely, sir. Thank you so much. And I think you have iterated so well that, early prevention and diagnosis is so important here. And I think in the second round of question, I will come back to you that how we can do that in the state of Uttar Pradesh and what efforts are being made currently. But before that, I will move on to, our representative from Tripura, Dr. Arindam. I think we have heard, various stakeholders here who represent, the different aspects of this entire, spectrum of cancer care, and at various levels they are placed. But in the state of Tripura, can you help us understand what is the scenario when it comes to the incidence and what exactly is being done, to tackle this problem?
Good afternoon, everyone. Okay, I have few data with me.
Yeah.
Like last few years, this is the leading cause of cancer in female.
Yeah.
Though male cancers are also there, male breast cancers. So in last few years, like last 4 years, if we are taking data for stage 3 breast cancer, it's like more than 450, almost nearby 450, and stage 4 is around 250. So for stage 3 and stage 4 cancers are coming more in our regional center because of lack of awareness, of course. So what we have started, like we have NCD clinics in different PSC, CSC subdivisional level also. So what we have started is, we have started few classes, batch-wise doctor and sisters in our center,
Right.
monthly, like yearly 3-4 times, batch-wise they used to come. We used to take class for 4-5 days. It's because of awareness only, and how they have to guide to send the patient in our institution.
Right.
So doctors from PhD level, CSC level, they used to come in our institute, yearly 3-4 batches. So we have started that. And one more thing is nowadays, so many health, this one sub-center converted into health and wellness center. So their community health officers are posted. So they are trained also. So they used to send patient directly to us.
Right.
Whatever patient coming with lump in the breast, whatever cases. So we used to register under preventive oncology branches. We used to do all the tests. If patient is okay, they will do follow up in the PSC level. If we get something, then we used to follow up those patients in our center. So we have started class. We have started all those awareness facility in our hospital. So likewise, we have started extra bed for preventive oncology patient, palliative care also.
Right.
So these facilities we are providing under NHM, under NCD clinics. So nowadays, patient used to come directly to our center because we have started awareness. We are doing 2 health camps monthly.
Right.
Clinic camp monthly.
Right.
Where oncosurgeon used to be there, radiation oncologist used to be there. So patients are increasing. Screening patients are increasing in our center, state level.
So in this, when you say that, the screening patients are increasing, so is this, again, can we, interpret it that, the early screening is actually the curve is moving towards early screening in your
Early
state?
screening, yes. We are giving all the facilities like below 40 years patient, we are doing ultrasonography. Above 40 years patient, we are doing mammography. So all the facilities are available in our center. So only detection we are doing.
Right. Absolutely. Thank you so much, Dr. Rindam, for that. Dr. Rath, I would like to come to you for this, that, we have this, heard, scenario at 2 state levels where we see that, a lot of health system strengthening work is being, done under NHM and, various other programs. But, there is still sort of, when we say that, yes, the situation is, or the incidence is more prevalent in urban areas, but the shift in, screening or the early screening that we keep talking about that needs to happen is still, really, has not taken, that seriously about, amongst the population at large. So what do you think that, beside these health system strengthening work, what really needs to be done so that, there is a population-based demand or awareness also for, early screening? Or where are we actually, really missing the, entire, solution here? What is the missing link here? Dr. Rath, do we have you with us? Sir, you're on mute. Could you please unmute yourself?
Yeah, can you hear me now?
Yes, sir. Yes, sir.
Hello, can you hear me?
Yes, sir.
Yeah. The only one thing which I'll again repeatedly stress that we must have, this early diagnosis program, and this can be only done by good education of our ladies through whether print media or electronic media. These are the only things, because as Dr. Hiralal also told, that the early diagnosis is the key to cure. So this program must be there through electronic media and print media.
Right.
Thank you.
Thank you, sir. Dr. Martin, we would come to you with the same question that, we've been hearing a lot of work which is being done, in the health system space. And I'm sure, Niti Aayog is at the, epicenter of, doing a lot of that kind of work and supporting the states. But still, when we say the population-based demand for early screening, which is paramount, however, still, people are very negligent, at a mass level when it comes to, being more aware about early screening. So what do you think, how can we build that awareness? Because that seems to us kind of, is a foundation of, beating the increasing, incidence of breast cancer in our country right now.
So, a lot of efforts are going on. If you look at the mobile health, M-Health, the use of mobile devices in health system is increasing.
Yeah.
Even we have been talking about apps for the ASHA workers, right? From that level, they're the workers who are the bridge between the system and the community.
Yeah.
So that can be used for raising awareness about early detection and screening for that. Apart from that, wherever the screening facilities are not available, high-end screening facilities are not available, we can push for clinical best examination. That's one thing which we can do. Basic imaging facilities are there from primary health center onward, but we say that how that can be done. But wherever a certain area, that means the triple testing, FNAC testing and other things, wherever is possible, because at community health centers, we have been struggling to find surgical specialists, but wherever many of the centers they have more than 60-70% they are having. Now, can that thing be used to examine the suspected women? But the main bottom line is the suspected women. How to arrive at that suspected women? The health and wellness center, the population-based screening, the clinical breast examination, even the medical officers and the other person, they need to be capacitated for doing this clinical breast examination, when to suspect, when to send the person for this advanced screening, even the triple tests which are there. Then the important thing, we have been talking about IEC campaigns, we have been talking about BCC campaigns for the last 2 decades, 3 decades. But from the communication, we moved to the information education communication. Then from IEC, we moved to BCC. But that is not yielding the desired result. That is the behavioral change. That's the end output.
Absolutely.
For that behavioral change, we should be having one-to-one patient education and see that how we can nudge the patient in finding any abnormalities. The early detection is the key. As mentioned by Dr. Rath and Regina Lalji, that cure is available. More than 95% survival rates are there. That means the bottom line is you examine the breast, detect as early as possible so that the woman can be put on treatment and that life can be saved. So that kind of mechanisms are there, and we have to see that how we can make these facilities available, for which skilling is required, capacities are required. We can engage with the different stakeholders at the lower level. We can engage with the Ayush workers also. We can take anybody who is willing to promote the awareness part as well as bring the people for detection and diagnosis.
Right, absolutely, sir. Thank you so much. And I think correctly said that, identification of the high-risk population and, with the right education, I think these are really important parts. And when it comes to breast cancer, we have seen that, there's a lot of associated shame and stigma as well, amongst people. And I think the right kind of education and behavior change programs are very critical there, and not just, amongst women, but I think it should be done, across, irrespective of gender, because men should also be aware what the incident, what are the high risks associated to it, so that they can also create, because conducive environment becomes sort of foundation when we have to build the entire environment of on the on the grounds of behavior change programs, right? And I think this was one segment about early screening, and talking about this being a preventable disease, but a very important part of breast cancer is also about having the right kind of data, right? And I think the need for cancer registries becomes really important here. And Dr. GK Rath, we and Dr. Madan, we would like to hear from both of you that what is your take on that aspect. Dr. Rath, we will start with you. Dr. Rath, do we have you with us here? I think we will circle back to sir again. Dr. Madan, can we hear from you, on the need of data and clinical registries when it comes to cancer and breast cancer specifically?
You say that the breast cancers are the leading cancers in India now. So from where this information is coming? It is coming through the data which is being collected. Now, if you look at the way things are happening, you talk about any cancer screening. The screening is happening, registries are there. ICMR is having the largest and the oldest registry, cancer registry. But that information needs to percolate, to be used, to be analyzed by different researchers, academicians, so that they can throw insights. So we have to work in that direction and see that how that data is made available. Second thing is the health and wellness care, wellness centers, which are the key. That is a game changer because from the primary health care, we have moved to the comprehensive primary health care, providing 12 set of services through that institution at the peripheral most level. That's the key. And population-based screening, the moment the population-based screening happens, you require a mechanism for collect data. And things are happening in that direction. If you look at the National Digital Mission, Health Mission, that's another pillar of the Ayushman Bharat, which talks about taking the care to everyone, everywhere, everybody, with the financial reduction in the financial catastrophe. That's the third pillar of the Ayushman Bharat, which talks about data, in which each and every individual would be having an ABHA ID, that is Ayushman Bharat ID, and that would be seeded into their electronic health records. If you recall that way back when the Clinical Establishment Act was enacted, at that time the country had the vision to create electronic health record, and we are moving in that direction. Once these electronic health records are there, then you would be using that records for analyzing and coming up with the social determinants and the other parameters, other factor which may be a risk factor for this. That kind of analysis can happen after that. So data becomes of a paramount importance. And we talk about data security, the other question which you will be asking about the data security and other things. You look at the people using the apps. Everybody, most of the people, they are having 40-50% of the population, they are exposed to smart cards, smart mobiles. And each of the mobiles contains not less than 30 to 100 apps. And each app asks for permissions.
Right.
And we give permission to access the files, folders, the calls, the SMS, as well as everything. But once it comes to the government or the public sector doing something, they say that data privacy is an issue. Nevertheless, the efforts are being made. They are reworking on the bill, the data privacy and protection bill. Work is going on, and see, you will be hearing more about it in the coming days. But nevertheless, data is a key. If you want to influence and provide inputs to the policy, you require data, so that you know that which kind of focus is required. Because we are having a envelope. Financial envelope is limited, and we have to see that how we reach the masses on a large scale.
Right.
In a very cost-effective ways using the available technologies, whatever technologies. So this is.
Yeah. Thank you, sir. And I think on the last point, I think that you've mentioned that we have that limited envelope. And my next question actually is to the states, so to Dr. Hiralal and to Dr. Rindam. The question is around that in fact, this year's theme for the cancer month is also breast cancer month is also closing the care gap, which is about understanding the inequities in the cancer care and taking people-centric actions. Now, when it comes to cancer care, another problem that we really see is the finances, the high out-of-pocket expenditure, and cancer care being unaffordable to many. These are some of the critical problems that we see. Now we say that we have a universal health coverage, but at the state level, how can we sort of make it more equitable when it comes to cancer treatment and other services around cancer?
For the cancer treatment, we do have facilities at district levels. If there we are not able to provide the required treatment, then Ayushman scheme is there. Under that, many hospitals are impaneled. They are going there for the treatment. And if that is also not sufficient, money is required. So our Chief Minister is giving from the CM fund the special funds. He is very generous in providing the funds from CM funds. So through these we are trying to meet the finances. And as I told earlier that awareness, if the more awareness, early detection, so better treatment, that is the three words. So in awareness, we can use social media, we can use startups which are working in this area. Still we are not using these. That's why I am mentioning over here. And use of women educational institutions, because there we will get bulk number the women who are our clients. and ASA, ANM, and CHO. Now we are expanding to cover the rural areas. CHO centers we are opening in bulk and as per our requirements. So we can use them. And in the last, I would like to mention that use of technology in this area, that is the artificial intelligence and the data analytics will tell us what to do and where to do in advance. So by using this technology, the benefit of technology, we can reach to our destination of early detection. That I used to say.
Yeah, right. Thank you so much, sir. And now we will move to, I think we have Dr. Shiromani from Tripura with us. Thank you so much, sir, for joining us today despite your, hectic schedule. So we are right now, talking about, so like in the first round we discussed, the critical problems with the early screening when it comes to breast cancer, and we were given, a very holistic picture of what's really been happening in Tripura and how, the graph on that early screening is sort of improving in the state of Tripura. But again, if we look at, the inequities when it comes to cancer care, one of the key problems that we also hear is about, high pocket expenditure, out-of-pocket expenditure when it comes to cancer. So cancer care being, affordable is one of the, again, the primary objectives of the government of India as well. So what is, what is the situation in Tripura with regard to that, and how is the government, sort of working to make, changes on that front?
Thank you, madam. In Tripura, exactly my previous speaker has said that Ayushman Bharat, that is a tremendous help to the patient. With that money, we after giving some medicine, we that remains money, we try to give the patient for our to make up the out-of-pocket expenditure. Beyond that one, we also get some these TAPs, Tripura Health Ministry's help. From there also we can get some amount of money. So from there also we try to help. It will be valuable to mention here that we are screening through one program, Mukabla. That is the Chief Minister's Mukabla. Perhaps you might have heard. This is the non-communicable disease screening program in Tripura that is going on. So through NHM, through Ayushman Bharat, there's some amount we get, we try to manage with this one, the out-of-pocket expenditure. You will be pleased that we are giving concession to even the treatment in Leniac and PET scan also, we are giving concession. Suppose outside we used to see that is 30,000, we give here PET scan only 10,000. That is a minimal nominal charge we used to provide to the patient services. So in this way, we managed to bring down the out-of-pocket expenditure. Still, we are facing some problems in newer molecules that are very expensive. So for the patient who are not affordable, that is really burden to this patient. Still, we are facing that one.
Thank you so much, sir. And I think it's really heartening to see that what, we have been hearing from Dr. Madan Gopal, that, the kind of policies that are being shaped. And I think that a reflection of that, how to a very significant, to a very large extent, in a very significant manner, there is success at the level of state that, you are talking. And I think that's a sort of, I think, sort of homogeneous approach that, we are looking at. And I think that sort of, kind of bring coherence to, policies that somewhere it's being framed, and the implementation in a way is going sort of in, in the right direction. We might be, coming to this session. So before we do that, I just, one question to all of you that, when we look at, strengthening the breast cancer care across, India, we also talk about, a multidimensional approach. So in your opinion, what exactly is that multidimensional approach? And it could be sort of, a futuristic approach also, in terms of solutions to you. But what is really, in your mind that comes, when we talk of a multidimensional approach to cancer care? Dr. Madan, we will start with you on that.
Nalini, please come again with the question.
So I'm saying that, this would be, the last round of questions. So these are more like the closing remarks. So I am just, trying to understand that, when we talk about strengthening the breast cancer care, at the national level, we also talk about, a multidimensional approach, of utilizing maybe different stakeholders, maybe the private partners, information technology. So, but in your opinion, what is, your take when we think of, a multidimensional approach? It could be a futuristic answer as well, but then, what do you think, what is, that last mile approach where
Yeah,
you
we say
see?
like we are having multidimensional approach, right? From price regulation on the anti-HER2 drugs, which have been brought under the price regulation. Cost-effective treatment is also provided for the deprived section of the vulnerable population under PMJ. Then we are trying to link the cancer registry with the Ayushman Bharat so that kind of mortality database can be updated on a regular basis.
Yeah.
These kind of things are happening. Apart from that, another things which have been tried is the hub and spoke model to increase the accessibility, as well as center acting as hubs and the spokes can spread out. That kind of models are being provided. And we see that how we move in that direction in future. But the bottom line is how to create awareness, in which the role of NGOs, how to build capacities for doing self-examination, how to build the capacities of the doctors or providers for clinical breast examination. Wherever that is not there, how to build capacities for the FNAC, how to build capacities for imaging. It's required to be done in that direction. If you look at the way we are doing the screening, are we doing adequate screening? We have to ask that question and see if the answer is no, and what we can do to increase the effectiveness of our screening program. That's a question which we have to ask. It's not just male statistics. All the women are there. If you look at the screening statistics for the Western countries, especially US, when 99% of the people, they get screened for their cancers.
Yeah.
More than 90% people screen for different kinds of cancer. But what is the screening percentage? Less than 10%.
Right.
In that less than 10%, we are having the first one cancer, and that's a message which is there. How to improve that thing. The rest of the things are there. Treatment is there, but people should come forward as early as possible. So we have to take care of that.
Right. Thank you, sir. And I think it's quite alarming, like you said, that, with the sort of kind of screening with the numbers, that we have for, what's happening and the kind of incidents that's coming out of that, it's really alarming. And I think it's really important for us to have a very rapid approach, when it comes to breast cancer. Thank you so much, sir. And sir, we'll come to you now to understand that, what is the, according to you, you're giving like a state perspective to us right now. So what do you think could be, that multidimensional approach when it comes to, strengthening breast cancer care in the states, or maybe at the national level as well? So you're on mute. Could you please unmute yourself? Yeah.
That is a very nice approach, multidimensional approach. First, we should strengthen the screening so that new cases can come to our hospital or any doctor in the earliest stage. That is very helpful, the screening program. And at the same time, the clinical setups should be upgraded in the hospitals. The multi-treatment facilities should be upgraded, and coordination of different sectors, like at the same places we have 3 or 4 hospitals, that should be strengthened, that coordination, so that in every cases should not be needs to bring these cases in the treatment center. And rest one or two things is that at the same time, the government political level also should take this cancer burden, because this is state affairs or national affairs. The political involvement or local leader involvement should be there, so that we can support from different angles. And other thing is that the there should be some uniform guidelines for the treatment of this severe disease, because
Right. Absolutely, sir. So I think you can talk more about the standard treatment guidelines. I think that's actually one of the most critical aspects for such diseases. Hello?
Yes.
Yeah, so Shromani sir, so the question is to you. So you were just talking about the standard treatment guidelines. So would you like to add more to that?
Yeah, we had one NCG, and we have one NCG guideline. Then NCG guideline should be strengthened, it should be strengthened, and new molecules should be included in this guideline, so that no one is deprived from the latest facilities. And in the PMJOY, we found this Ayushman Bharat, so many things are lacking. So we are not able to provide the full support from, as the clinical point of view, we are not able to treat the patient in a full swing manner. So we are restricted somewhere in the Ayushman guidelines also. That should be uniform and discussed and to the limelight. So what is the hurdles? That hurdles to be solved. I think this will solve our treatment problem very smoothly.
Right. Definitely. Thank you so much, sir. And with this, we come to the close of our today's inaugural session. And I think in this session, we had, a really great representation from the central and the state level. We saw, what exactly are the policies and what is really being done at the level of government and how the implementation is taking place, but also where are the gaps. I think that was largely overall what the discussion was about. And with this, we'll close the session, but just knowing that breast cancer-free world is possible, but acting early on that is really paramount. With this, I would like to invite Riddhi Lakra, who is my colleague and would be moderating the next session for today. Over to you, Riddhi.
Thank you, Nalini. Thank you, Dr. Nalini. I will take over from here.
Thank you.
We would just wait as all the other panelists would join us.
As breast cancer is the #1 type of cancer in women today.
मुझे आज ब्रेस्ट कैंसर एक्शन डे से उम्मीद है कि जागरूकता और उपायों के बारे में लोगों को बताकर हम देश में ज्यादा लोगों के बीच कैंसर होने से रोक सकते हैं।
I'm confident that the contribution of the Integrated Health and Wellbeing Council will certainly help in checking and treating cancer.
That this is preventable, provided we feel ourselves on a daily basis. We love our bodies, we value them and take care of them.
The problem is really at two levels. One is with the media centering a lot of communication around what is significant in that month. And the second is, as a society itself, we just don't want to mention the word breast.
We have to create a complete ecosystem which can really help early detection, early treatment, and help patients live a longer and healthier life.
The most important thing is to be aware of the risk of, that you're a female, you can get breast cancer.
We need a multidisciplinary approach to tackle this menace. We need to have a multi-pronged strategy comprising awareness programs, need to take preventive action.
Amongst all, as per the ICMR, recognize that the most deadly one is the breast cancer.
We must channelize them towards adopting a healthy lifestyle that will reduce the risk of cancer.
If our female students become aware from the very beginning of the life, then the chances of breast cancer will be reduced considerably.
You should live each day as it comes, and then you aspire to inspire before you expire.
I see a lot of hope in CSR. Corporates can have a cancer fund for their employees. Why not?
Basically, bring the funding agencies together and to channelize, harmonize, and prioritize cancer research in India.
Make the education better for consumers, but also the education has to evolve for the medical professionals, the nurses, the health staff, and all of that. Put the budget together. How do you find someone to be able to fund all of this?
There must be teamwork or integrated approach of breast cancer management.
It's really about driving education, sharing the latest information, and building a platform to allow exchange of different ideas.
I welcome all for the third Breast Cancer Action Care Day Summit for the panel discussion. Breast cancer is the most common cancer amongst women that affects almost most in the middle and the old age groups in most parts of the world. I'm Ridhi Lakra, assistant editor, IHW.tv. The incidence of breast cancer is showing an increasing trend and affecting younger women, and the cost to prevent, treat, and manage this chronic disease is continuously escalating. Universal Health Coverage, UHC, is an initiative by World Health Organization that encourages policymakers in countries in the world to organize their health systems and then that are responsive in providing access to the quality healthcare. To talk about this, how universal health coverage is available and has been implemented in India, we are joined by speakers. We have with us Dr. Ms. Urvashi. She is a director, Development Monitoring and Evaluation Office, Niti Aayog. We also have with us Dr. Bhavna Sirhoi. She is a medical director, Balco Medical Center, Naya Raipur. We also have with us Dr. Gaurav Agrawal. Dr. Gaurav Agrawal is a professor of endocrine and breast surgery and chief medical superintendent, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. We also have with us Suranjeen Palim Pompola Prasad. He's a director, partnerships and program president, public health professor, state program manager for Jharkhand. I welcome all of you for this panel discussion. As Ms. Urvashi and Dr. Bhavna are not here, I would like to start with you, Dr. Agrawal.
Good afternoon, everyone.
Dr. Agrawal, firstly, to understand, there's a very important gap what we have. When we talk, there are healthcare workers, especially at the tertiary level. They have been identified as a key resource for educating women about breast cancer. But access to rural and undeserved population is severely hampered by the lack of untrained medical professionals, such as doctors. Innovative tools or strategies that we could overcome this problem.
You are only. I'm only to. Hello, am I audible? Am I audible?
Yes, doctor.
I can. I could not listen to you, or I couldn't hear you very clearly. What is the question posed to me?
This is about how, doctor, there are healthcare workers in the rural area, but they are not trained as well to identify the breast cancer. Though they are like Anganwadi workers, they are being trained, but it is not the right way. So how can we have more innovative tools and strategies to overcome this?
Oh, great. So happens incidentally. At this moment, I am sitting in one such initiative. We have our SCPGI breast and cervical cancer awareness and early detection program, which we have undertaken in our nearby Tehsil of Mohanlalganj. And what we are doing is we are training all the healthcare workers of this Tehsil, be these doctors, nurses, ANMs, CHOs, the community health officers, and ASHA workers. We are training all of them for helping us create awareness about breast and cervical cancer, and then also carrying out screening programs. And the reason I'm stating this is that this might actually be one of the strategies for us to go forward. The NCC DPS, the national programs too are using a very similar strategy. What we are doing, though ours is a more focused one, that we involve, as you said, all these community level workers. We go to them in their own work setting and take with us whatever training tools we may have. We use a mix of didactic lectures and then on-hand training programs where we, besides using some mannequins or inanimate models, we help them So we help them understand what kind of awareness programs are to be conducted, and train them in clinical breast examination and cervical cancer screening by way of visual inspection with acetic acid application. These are the two methods that we are using, and these are the ones which have been advocated by ICMR in our clinical practice guidelines. Now, how do we reach out to a wider masses, wider spectrum of community health workers? That is a big challenge. We can have focused programs, the kind that we are having, but it may be better if we can have a mass approach, relatively reaching out to a wider spectrum. This can be district wise to begin with, and then sub district wise we can chalk out. And there are number of examples across the country where either on state level or on district level, I'm sure you'll be discussing the Kerala and Tamil Nadu models and perhaps a few others where community level workers are being trained in a very similar way that I described.
Thank you, Dr. Agrawal. Like you have highlighted a very important point, like how reaching the masses would be a very good solution, and focused programs would be like one of the other solutions. And you also gave an example like how states have already adopted like teachings of like the group through mass approaches. Thank you, Dr. Agrawal. Dr. Prasad, I want to come to you. Doctor, when we talk about like how breast healthcare is being enhanced in environments, like when we talk about the environments where is a limited resources and income is available, so what would be like a strategic interventions here and the investments that can be implemented, and we can scale up this entire procedure of allocation of resources according to the various health needs amongst the women for the breast cancer? And how do you think breast cancer health can be enhanced in environments with limited resources and income?
Yeah, is this question for me?
No, Rishi, that's for Dr. Prasad.
Oh, okay.
No, interestingly, both of us are Prasad. So, yeah, I'll take that. Yeah, thanks, Riddhi, for that question. And I'd like to give my salutation to Dr. Gaurav. Hello, sir. It's nice to be on a panel with you. So really, to just summarize the question, I think largely you were asking of, how does public health allocate resources to make sure that, how can public health resources be allocated better to make sure that, screening can actually happen, at the grassroots level. So that's an important question, and what I would say is that level one of allocation of resources has already happened, and interestingly, it happened 10 years back, or more than 10 to 12 years back. So 10 to 12 years back, the government has actually allocated resources and adequate resources for ensuring that women actually are screened throughout the country. The main issue here is in the utilization of these resources, and that is where we are having difficulties. If you look at the latest survey, what we call the National Family Health Survey, which looked into this, what we see is that even after allocating a huge sum of money to this, and every year states continue to request for that money, just only 5% of women have been screened. That's what the NFHS 5 report says. We as an organization also want to understand why this happens. And what we noticed was that it was a mixture of 4-5 things. One is that the government, though had resources, did not really review and track to see how efficiently this program was going on. And so it was a problem of having a kind of a strong programmatic managerial support where people were held accountable or people were asked to report. In the 1990s and in the 2000s, we saw the same thing happen for routine immunization. And once that became tight and once things became streamlined, we saw routine immunization go up. We saw the same thing with institutional deliveries. Though there was a policy mandate, once reviews and mechanisms to hold people accountable came into place, we saw that institutional deliveries again went up. And there are multiple other factors, but that's number one. Number two, what we saw was that the primary worker that was meant to do the screening happened to be the auxiliary nurse midwife. What we found is that most auxiliary nurse midwives were not confident even after they received the training. The training, unfortunately, was just for around 2-3 hours. And it was assumed by the state that just by giving 2-3 hours training, one can do. Dr. Gaurav was mentioning that at this moment he's in a training program. And he probably, and others would understand what it means to pick up skills and what it means to mentor somebody who's got skills and continue to build their ability to have this to happen. And the third most important problem was what I call micro planning. One was the mega planning, the other the micro planning. Now, when I'm expecting this to happen at every village, I need to see that at every village, there is a conducive plan and an environment to actually have this to happen, this screening. Especially when you're looking at breast cancer and women's cancer screenings, there are a few things we need apart from the skills of the health worker. We need a place where we can keep she's not a patient, she's a normal person, to keep the woman comfortable, privacy, to make sure that the woman is comfortable to be examined. I think these are some things we have not yet cracked, and these are the three things I believe if we are able to crack and answer, probably we can take off and use already allocated funds efficiently and take this forward. Thank you.
Thank you, Dr. Prasad. For highlighting the lot of important points. How is it important to the training is important. And you also mentioned about a very interesting thing that the National Family Welfare Scheme, the survey said there's only 5% of the women who are being screened for breast cancer. We need to increase that. That can be done with a lot of awareness creation, and plus more funds should be invested for this. Thank you, Dr. Prasad. Urvashi, moving on to you. I want to ask, there are differences in how specific communities experience and are impacted by the breast cancer incidence in terms of the mortality, survival. So these are the disparities in breast cancer system, and from a complex interplay of several factors that lead to a variety of one is the social injustice, including the majority inequalities in the healthcare. So to begin with, in your terms, could you elaborate why universal health coverage matters and it's ensuring an optimum care for breast cancer management?
Yeah, so, when we look at any cancer management, and also true for breast cancer, we have to think about the entire, spectrum, right from prevention to early detection to treatment. We have to think of all the different dimensions. And that is what universal health coverage is all about, where you plan for and think about all these different dimensions of care. So I think firstly, prevention or other health promotion is important. That a public health approach is best suited for, because it's not a doctor or a specialist job to really, sort of create that general the job of a public health practitioner. So we need a public health approach where we promote good health and well-being. Then in the primary care level, we need to really focus on early detection, because we know this for all cancers, and it's true for breast cancer also, that the earlier you detect, the more effective your treatment is likely to be, and it's also likely to be less costly for the health system to treat a patient who is detected at an early stage. So it's very important that in primary healthcare we push the early detection paradigm. We have to promote breast self-exam by women, because every woman might not always be able to get a mammogram, and it might not even be the most appropriate for every woman at every stage. But at least a self breast exam must be promoted, and women must be able to bring up any issues that they feel with regard to their breast health. So I think that awareness is very important. And then we of course need to look at the treatment side of things. We need to make it affordable. Under Ayushman Bharat, we are providing health insurance to people below a certain income level. We need to expand the gamut of that. We also need to serve the the missing middle, as we call it, because not everybody falls into the poor bracket, but there are still a lot of people who don't have insurance cover, health insurance cover. So eventually we can look to expand programs like Ayushman Bharat to this missing middle segment as well. And I think finally I would say that research and innovation is critical, because we need newer, more cost-effective diagnostics. We need better, well-tolerated treatment regimens. So investment in research, investment in innovation is really very important. And we also must alleviate the social stigma, because when it comes to cancer, and a cancer which affects women, there is often a lot of social stigma, and women don't come forward for screening, or they don't raise any alarms to the health system if they notice any problem. So this stigma must be addressed, and of course this requires us to work with men and women, but we must use all the diverse social communication channels that are available to us. And again, I would emphasize public health in this, because it is the role of public health practitioners to create awareness and address stigma.
Thank you, Urvashi. Urvashi, you mentioned about technology. In the same lines, I would like to go to Dr. Agrawal here. Dr. Agrawal, how do you think the role of health technology assessment plays a very important role in universal health coverage, and how imperative it is to understand the current dynamics of the breast cancer care in India? Dr. Agrawal, you're on mute.
Well, that's a good question, and I think there cannot be two opinions about how we can leverage technology, especially low cost and appropriate technology, including telemedicine and teleeducation technologies, to scale up our capacities in remote areas, both in terms of training of our healthcare workers, as well as in terms of care of any women who may be having some suspicious or high risk conditions. Fortunately, a lot of telementoring can now be done, and we are using some such strategies with good effect. So, indeed, technology is going to help us scale up our operations and bring down the overall cost of both training activities as well as care of our patients. Telepathology, teleradiology, they're all very much practically doable currently, and we can, but of course we cannot do away with on the ground manpower altogether. These clients would still need to be contacted at their home or in their communities to begin with, and then we have to have appropriately trained people in the PHCs, in urban health centers and sub-district hospitals, where the primary care can be meted out. Eventually, they can be all referred. At least some of them can be referred for some part of the treatment to appropriate district hospitals and medical colleges.
Thank you, Dr. Agrawal. Dr. Prasad, I want to come to you and ask in the same lines like Dr. was mentioning about like the telemedicine and training of the healthcare workers through telemedicine, and telemonitoring is also one of the things. So doctor, like what are the new, like the healthcare system, like in the public healthcare system has been improved to strengthen the universal health coverage, and like especially in the diagnosis and the treatment, what are there, if you could explain.
So if you're talking about diagnosis and treatment, the for screening, there's a very well laid out program, as I mentioned, but unfortunately, it's not efficient. In the sense, the program as a plan is quite well spelled out. But when it comes to diagnosis and treatment, unfortunately, we don't even have a well spelled out plan for the public health system. From an individual institution understanding of what we need to do for diagnosis and treatment, yes, there are clinical algorithms that need to be followed, and that's present. But I'm talking from a public health approach. Like for example, and this is something we began actually working in the state of Odisha to help them address this. So, for example, if a person is picked up at a village in Odisha to be screened and has a lump in the breast, what is the protocol? Would they be referred to a sub-district hospital? Would they be referred to a district hospital? Where would their definitive biopsies be taken? Where would would an ultrasound scan need to be done? That unfortunately is not defined at this moment. Everything in the state of Odisha would finally land up in what we call the regional cancer institute. That would be the Acharya Harihar, and it's the same everywhere. So if you go to a state like Jharkhand, everything would come to the medical college at at Ranchi, and this is what we are seeing, the missing part in the middle. So we've been working with certain governments and largely with the government of Odisha to try to see how district hospitals can actually become empowered to play that role in diagnosing for cancer. And then we could talk about the next level, which is in initiating and following up on treatment. So it's in a line. What I would only like to say, it's something that I think somebody has to come with a model, and then make sure that most states are comfortable and would take this.
Thank you, Dr. Prasad. Yes, a lot of other states, like most of the states have to start developing their own ways of breast screening and the other technologies within their states. Thank you, Dr. Prasad. Urvashi, moving on to you, we see that like everybody is talking about the technology. They're talking about the diagnosis, the treatment, and the management here. But what do you think the role of the government can play in promoting and facilitating the universal coverage to breast cancer diagnosis, treatment, and the management?
Yeah, so I think government has a very important role to play in the entire public health system. So when it comes to issues like awareness, alleviating stigma, early detection at the primary healthcare level, as well as health insurance cover for the disadvantaged. All these are areas where the government has a very important role to play. And also in fostering and promoting research and innovation. Of course, investment also needs to come from the private sector when it comes to R&D. And we also need to see innovations coming from the private sector, from our startups, from organizations like that. But the government has an important role to play in fostering and promoting that overall research and innovation ecosystem. So I think these are some very important roles for the government. Also in capacity building of health workers, because you need to build the capacity of health workers at every level to promote, breast self-exam among women, to give them the right kind of awareness, the right kind of information, as well as pick up any early signs or symptoms of, disease that women might be facing. So we need to train all kinds of health providers to, pick up these early signs and symptoms, because, everywhere you cannot have a breast cancer specialist. Somebody might interface with somebody else in the health system. You might meet a nurse, you might meet a community medicine practitioner. So everybody needs to have some basic awareness at least, so that they can, gynecologists, they need to, all have some basic awareness of this problem. Because, women might actually come to them, and they might be the first interface that women have with the health system. So I think that capacity building of health workers is also a very important role that government has to play. But I think overall in public health, in prevention, in primary care, these are especially very big responsibilities of the government.
Thank you, Vishi. Yes, the government needs to play a very important role here in creating awareness, in everyone, as you said, there are not specialists available everywhere. We have to create more awareness. We have to teach the healthcare workers, a basic awareness should be there with everyone. Moving on to you, Dr. Bhavna, you're here. Dr. Bhavna, we all see there is a lot of there is a lot of barrier in in receiving a high quality breast care health if somebody is having a breast cancer. So Dr. Bhavna, could you elaborate on some of the factors that is actually acting as a barrier to receive a high quality breast health care in India?
So thank you, Riddhi and Ivana and Dr. Nalini. I mean, from IHW Council, first of all, I must congratulate you and thank you for doing this in the Breast Cancer Awareness Month, because I think events like this are very important for education and removing those barriers. I think the most important barrier we have in India is we do not even use the word breast. So that's the biggest stigma. So how can we talk about breast health when women don't want to talk about their own breasts? So I think, first of all, we have to destigmatize the word cancer and also breast cancer. So a lot of women, despite having a lump, I see women to this day, I'm working in Raipur in Chhattisgarh, they come with a fungating breast mass when the wound starts smelling. And that's when they come, or it starts bleeding. A lady presenting with breast cancer with a hemoglobin of 5 is something, which, I mean, in the West, when I was in UK, nobody had heard of this thing because, you think breast cancer will present with a lump, but to present with bleeding with a hemoglobin of 5, you would expect that in a GI cancer. You would not expect that in breast cancer. So I think the key barriers we have, number one barrier is education and awareness. And so we need to actually, it doesn't cost anything. We need to increase awareness about self-breast exam in a monthly intervals and an annual clinical breast exams. When I see JH Pygo is there, a lot of other organizations, they are doing amazing work. So once a year at Community Health Center, the Indian government, I think, has done a great job in starting this program of doing clinical breast exam annually, which you can get it done at a PHC or CHC level once a year from the age of 30 years onwards. One should know how to, so it should be done by somebody who's trained in doing it once a year. So education, awareness, breast exam, and also mitigate the risk factors for breast cancer. Trying to, the things which are very easy to do is avoiding oral contraceptive pills for a long period, or if you're using hormone replacement therapy, use the estrogen only one, because we know that decreases the risk. Should not use the combined pill for long periods of time. So being breast aware, and then, diet and exercise, they have a huge role to play in preventing cancer. So this is something we must really drive. And also, I think the biggest barrier that we have in the country today is that the big cancer centers where you have amazing breast surgeons who know the principles of breast surgery, you know, trying to do breast conserving surgery, trying to do, I see Dr. Gaurav Agarwal is here from SGPGI, Dr. Soma Shekhar is here, to do the sentinel node biopsy, or, you know, something which actually de-escalates the breast cancer care without compromising outcomes. So this is available in tier 1 cities. It is not available in, it is now in some cities in tier 2, but tier 3 cities is where most of India lives, or rural India. So we don't have cancer centers which are available there. So there is problem of access, there is problem of affordability and availability, which are the biggest barriers which we need to mitigate as a group. And I think with the rapid program that you have started from IHW Council, I think that is one thing which will make an impact not only in India, but I hope it will make a global impact as well.
Thank you, Dr. Bhavna. As you said, like we need to destigmatize the word breast and also cancer, and that is also one of the important thing in India, that we start talking about breast cancer like normally, and that would be like a way that the women would start coming to their maybe the smallest healthcare at their level, and in the earlier stage they can actually identify breast cancer, and the treatment can go on further. Thank you, Dr. Bhavna. Dr. Agrawal, coming to you again, when we understand, we were talking about destigmatizing the term cancer and both breast and cancer. What do you think, doctor, how can we start doing this? So there is medical schemes available in India. There are awareness also there, but do you still feel we are not able to reach the masses? Is there a very big problem here of not able to connect to the rural women, like the India, as Dr. Uroshi, Dr. Bhavna was also mentioning that the tier 3 cities do not have so much of facilities, whereas the tier 1 cities have the best surgeons sitting and doing the surgeries for the breast cancer. So how do you think we can bridge this gap and also create another level of awareness amongst the women for the breast cancer?
Okay, so I think let me say this first. The beginning has been made, and we are seeing some progress on every front. No doubt, the glass is still 1/4 full, and we still have to fill the rest of the 3/4, perhaps at least 2 more quarters. But we are no longer in the same stone age, perhaps, which existed 3 decades or 2 decades ago. We are, as Dr. Bhavna said very correctly, our government has taken a number of initiatives. The civil society is putting efforts in the right direction to destigmatize awareness about these key health issues in women. There is quite a bit of open discussion now. And again, I'll have to say it, that everything is comparative or right now we do have some discussion going on in popular media, in social media, which, by the way, happens to be, in my mind, the game changer. So much more exchange of knowledge and information and ideas is happening thanks to the social media. So indeed, there is quite a bit of progress being made. I'm sure my colleagues, my clinician colleagues in the panel would agree. We are seeing and treating a much larger proportion of early stage breast cancers today compared to what we were doing a decade ago or 15 years ago. And that's certainly a welcome change. But going forward, what further should we need? What further needs to be done? I feel the popular media of whichever form need to be harnessed to mainstream these discussions. Why are we still not having a discussion on breast cancer in this month of breast cancer awareness? I do not see a discussion happening on a popular TV channel on breast cancer awareness. At best, you may find one or two discussions here and there happening as in form of an editorial or a sponsored program. Why is it that our advocacy is so weak that we are still not able to convince editors and channel directors to bring this to the prime time? So what I'm pointing at is all of us need to put in some efforts to mainstream or prime time this discussion rather than being left to the fringes of some editorials or inserts in newspapers here and there and Femina magazine or another women-centric magazine. Secondly, I mean, a lot is being done by the government, but further needs to be done. Much more efforts need to be put in for, again, mainstreaming these things. Some of the messaging that I see coming from various government agencies are fantastic. I mean, there's no dearth of talent and creativity in our system. Messages are being put in very effectively and with a lot of sensitivity towards not making it neither alarmist nor anything being seen as gaudy or obscene. So if that is available, why is it that we are not doing this even more? Why are we not seeing billboards and hoardings at the prominent crossings of our cities and level 2 and 3 towns to disseminate the message of breast cancer awareness and public health awareness in general? And that is where I think further progress is what is required. And finally, the third point, some of our best public health efforts and successes have come from involving a wider section of our society, including the celebrities. I mean, this is one sore point in our society. Why are Indian celebrities not coming forward to mainstream the discussion on breast cancer awareness and public health awareness in general? Why are the Amitabh Bachchans and Shah Rukh Khans of India, and for that matter, any prominent cricketer or other sports people, not talking about breast cancer awareness? Of course, I when I say this, I'm not saying that. I am part of those responsible. Perhaps we have not made sufficient efforts or serious enough efforts to compel these public figures to start talking about.
Thank you, Dr. Agrawal. It is a very important issue, Doctor, that we start this, as you said, the progress has been made through the social medias. We are talking about it, but then it's in a very smaller scale. We need to bring to, as you said, we need to put more efforts to bring this to a prime time. The billboards of the cities should talk about breast cancer, and even the celebrities should go mainstream with the public health care. That is what we would also love to do, and we would also encourage them through our panel sessions, Doctor. Thank you so much. Moving forward to Dr. Prasad. Dr. Prasad, are you here? Yes, Bhavna, you want to say something?
Yeah, I just wanted to say what exactly, just taking on from Dr. Gaurav's point, that in the Indian movies or even the movies internationally in Hollywood and Bollywood, so if somebody has to die, they actually make sure, most of them, they have cancer. So the narrative is negative. The message doesn't go out, that with all these strategies that we are talking about, that if you diagnose cancer early at stage 0 or stage 1, it's completely curable. Khansi zukham ki tarah theek ho jata hai. But, in movies have completely created this big fear in people's minds that, you got cancer, I'm going to die. So that narrative also should be changed through the movies, I feel.
Yes, Dr. Bhavna, thank you so much for adding that. Dr. Prasad, coming to you, we were talking about creating an awareness through the social media and other medium platforms, but how do you think we can also strengthen our any specific measurements we need to take to strengthen our breast cancer diagnosis treatment into a public healthcare sector, and adding on to the universal health coverage, what are the main measures we can take?
So I think, I talked about this, just just before, on the importance of actually having each of our district hospitals having the capacity to be able to diagnose breast cancer. Urvashi also pointed out the fact that we could bring in the private sector also in a big way through the insurance mechanisms, both the government insurance like Ayushman Bharat and others, and the private insurance, to have this to happen. And I think that's something we need to do. So from a public health perspective, there are 2-3 things to make sure it happens. One is ensure that there's a signaling and there's a kind of a review and accountability fixation for this to happen, and this to take place. The second one is to make sure that clients also know about this and start getting to use it and start getting to demand for it. And I think that's what happens. Most of us, as has been mentioned both by Dr. Bhavna, is that most people actually walk into a medical establishment only when it's very, very obvious. And we are talking about picking this up actually when it's not obvious. So which means that one will have to get screened even when one does not believe one has a problem. And that is a whole mind set change of getting checked even if you don't have a problem. Nowadays, even at home, when I get a headache, and since most of us have a blood pressure machine at home or something, immediately people say, okay, take out the blood pressure machine and check if you have a thing. But why should we wait for a headache to check if somebody has got a hypertension? Hypertension can certainly come in. And so I think there are certain norms about screening that needs to be set within the public imagination. Unfortunately, that's not even been set in the so-called middle class that can afford care. If you ask, say, a European or an American, screening is almost set in them, and it's so much set that in some places the public health, people send you a birthday card and says that this is your birthday and now you're eligible for a screening for colon cancer or screening for XYZ. So unless it becomes part and parcel of the public health norm, the public understanding, that this happens. And I think that's where we need to be talking more on how do we get this to happen? How do we make sure that this happens? When we were looking at what was happening, say, in Europe or America, in the 90s or in the 80s, again, there we see, that it was not a part of the public discourse. It was not a part of, these norms. And then it suddenly came in there. And one of the reasons that came in was there were a lot of breast cancer survivors who took it upon themselves to make this known. And actually, there were a lot of people who pushed this. And they pushed it with very interesting things. They pushed it with the pink ribbon, they pushed it with runs, they pushed it with multiple things. That so much so that this became part and parcel of the, the public talk, discourse, and as I'm talking, the public imagination. What it would take in India to move this? Who would it take? Would we want to wait, for an organization to, make it like a norm and, like a Gates Foundation or something to do it off? Or can we bring this up, bottom up instead, and, and bring this. The second one, what I wanted to ask was, I'm talking directly to our own medical community. What I see is, prevention as a thing. If I talk to any pediatrician, definitely a pediatrician would somewhere in a conversation, even if a child comes with a cough and a cold, will ask, have you been immunized? That has become a norm within a pediatrics training and discourse. But even if a woman walks to a gynecologist multiple times, what we have noticed is the gynecologist rarely asks, have you been screened, for a breast thing? I can just do it. It's a 2 minutes thing. Would you want to do it? So even, this opportunistic chances also, most of the medical communities, do not, ask. And it's not a part and parcel of even the medical community discourse and push. I'll stop.
Thank you, Dr. Prasad. But just a curiosity, what I have and I want to ask, like, do you think when somebody walks in like with a normal fever, and if the doctor would ask them, would you like to do a breast screening? Don't you think the woman would get scared? Is there a way that doctor would make it more simpler for them? I would like to ask all the panelists here, Dr. Gaurav also and Dr. Bhavna also, as well. How do you think we can make this more common? Like, as a patient walks in, to a gynecologist as well, and with an other disease, but they are asked for doing so screening for a breast cancer. How do you think we can make that more simpler? Dr. Bhavna,
So in UK, when I was there, the uptake of screening was, even though it's freely available, and the state looks after you, they have universal health coverage. You get a letter in your post when you turn 50 that you're due to have a mammogram, and the surgery sister keeps calling you till you have the mammogram. So there also it was seen that the people from Asian and Black and ethnic minorities, they did not take up screening. So, and I worked in Northeast London, where most of the community was from this group. So what we realized was that when a patient with cancer comes, if you actually speak to the relatives, that is the right time to actually, each person has at least 15 to 20 relatives. So even if you actually talk to them, the uptake of screening is very high in those patients. So I think each one of us as oncologists, we have a duty to our country to diagnose cancers early, because our outcomes are very poor, and the outcomes are poor because most patients come late. So every cancer patient who comes will have 30 to 50 relatives and members who may be eligible for screening. And also for things like, tobacco cessation, for HPV vaccination. There are some strategies which we know will prevent cancer. So we should at least target those, in my opinion, because, they are very receptive to that idea.
Dr. Agrawal, what would you say about this?
Well, yes. I mean, the possibility that you expressed, that we do opportunistic screening for every woman walking into a clinical facility seems very attractive, but this is possible only when it is done very tactfully and sensitively. I agree that we cannot be alarming women, and the fact is that not many of them would actually turn out to be having something sinister. Only a small proportion would actually have something significant. But yes, this seems a really attractive proposition. Any woman coming in can certainly be given some information. This information can be in form of a printed pamphlet or a small video clip being played in the waiting area of the hospital. Some posters and other displays being put up at the vantage points in the hospital while the patient is waiting or the relatives are waiting. They can go through this to make it attractive to them, that while they are here in the hospital, they might as well get themselves screened. But practically, I mean, our society is perhaps not mature enough right now to be able to digest that kind of a proposition. What I see in our patients and their relatives, while they're waiting in the hospital, they are happy to go to a nearby eating joint to pass their time and perhaps talk about all possible other things, but to talk about medical issues. So yes, it seems. I mean, honestly, I have not put in my mind or my thoughts very seriously how to make that attractive to women waiting in a hospital. But it is something which is certainly worth a try.
Thank you, Dr. Agrawal. Dr. Prasad, as it was your idea, would you also give an idea like how we can make it more simpler to approach women to go up for the screening process?
Yes, as Dr. Gaurav also mentioned, so my point is that we need to make this a kind of a norm, more than definitely opportunity screenings and others are opportunities where we would, want to catch. I mean, we want to increase what we're saying, we're casting our net where we are standing from, so because we are in the hospitals, we believe, then we can cast the net closer there. And we were looking at, how that would roll out. But I think as a norm, we have to send out messages, that these things are important. Just getting screened doesn't mean that one has it, but screening is equally important.
Thank you, Dr. Prasad. Coming to an end to this panel discussion, I would like to ask a very important question to all our panel members, starting from you, Ms. Urvashi. How do you think we can expand and access to essential quality service for breast cancer patients in India as part to achieve the universal health coverage? Firstly, Ms. Urvashi, starting with you.
I think she's not around.
I think Ms. Urvashi is already left. Dr. Bhavna, I would like to start with you. Like, how can we provide access for essential and quality services for breast cancer in India?
So I think we have to think innovatively and laterally and utilize telehealth services for remote parts of India. And everybody has a phone. So through the government, things like breast exam videos about breast awareness, about HPV vaccination, the right information from the government should go in, and it should be there on all the websites and, state-run local language channels. We should use that to the full potential to, get the message across that, this is what you need to do. Only then we will, cause a stage migration from stage 3 to 2 and then 1 and 0.
Thank you, Dr. Bhavna. Dr. Agrawal, your takeaway points.
I think I can think of these 4 steps towards this. The first step has to be in form of various efforts and measures that we can take to assure our country, countrymen or countrywomen, if there's a word like that, of all possible help from the government and civil society in case a family, a woman is diagnosed with a cancer. How do we do that? Making sure that there are sufficient public health facilities for all such people who are afraid of the expenses of diagnosis and of treatment. Once, see, this is something that I say because a large majority of women who are afraid of getting tested, even though they may be aware of a lump in their breast or any other symptom, yet don't want to come forward for examination and treatment, is the cost involved. They are very afraid that this will rob their families of the scarce financial resources that they have. So if we can assure them that whatever is the cost, a majority of it will be taken care by the government or by the public health setup. Of course, a small proportion of them who either have insurance or have sufficient personal funding, they may be an exception. But with expanding net of the Ayushman Bharat and similar schemes, this is something I feel quite doable. And secondly, the second step is to, as we were discussing earlier, destigmatize breast cancer or cancers as a whole, and making aware women and society as a whole of curability of this disease, especially when detected in early stage. So the two fears that majority in the community have are the expense and loss of life and mutilation and morbidity. If these messages are available or are sent out loud and clear for everyone, that no, it's not going to cost your lifetime savings, and it's not going to cost you your breast, or it's not deadly if you get treated early enough. Perhaps we would make whatever efforts we already have or whatever facilities we already have for a treatment being picked up relatively earlier. Second step, I agree with what Dr. Bhavna said, leveraging on technology to make, again, it's more of information dissemination than other things, disseminating the facts or disseminating the information regarding how breast cancer can be diagnosed, how can it be detected by self-examination, what kind of clinical breast examination can be undertaken, where and how breast screening imaging can be done, ultrasound or mammography, and generally how is it treated, including putting emphasis on the current day not so morbid, not so mutilating treatment options of breast conservation and durability of the disease. Similarly, the same technology can be leveraged to make screening, detection, diagnosis, treatment, and follow-up a little more convenient for women who are not living in cities where these facilities are available. Of course, coupled with, as I said earlier, coupled with at least some basic facilities being available at the grassroots level. Telemedicine, teleconsultations, teleradiology, telepathology, all these things are usable, provided we have at least the most basic facilities available locally, and rest can be augmented using telemedicine. The third crucial part of this, making universal treatment approach or making available breast cancer treatment universally to everyone, is to make more, increase the number of facilities providing free of cost or low cost treatment options. And this is not necessarily only the government hospitals and institutions. We have quite a large network of private hospitals and charitable hospitals which treat patients who are beneficiaries of Ayushman Bharat scheme or similar other government schemes. So it's not something that only the government needs to do. We need even larger network of these empaneled hospitals to be able to treat patients out of or supported by these government schemes. And in that manner, one further tweak that needs to be done is that the Ayushman Bharat scheme and similar schemes, they need to up their coverage, both in terms of width of coverage, which means a larger spectrum of population, including the missing middle, should come under the wings of these schemes, and the depth of the scheme, and perhaps that will mean increasing the funding available to the families and to the treating hospitals. And finally, the fourth and perhaps the most crucial step is that let a large, but one opportunity that is almost going begging is the government has made it essential for all corporate to spend a certain proportion of their revenues as part of their corporate social responsibility. And I'm sure all of us have, we are aware of so many corporates supporting non-essential fields or non-essential activities out of these funds. Why can't we tap a substantial proportion of CSR funds for making this treatment available widely? Not just treatment, but screening, awareness, detection, diagnosis, and then treatment. So these are the four things that come to my mind, which might help in making breast cancer treatment available universally to our population.
Thank you, Dr. Agrawal. Dr. Prasad, your takeaway points.
Well, thanks a lot, for having this discussion. It's an important discussion. I think Dr. Gaurav has really, spelled out, in minute details on what needs to be done. And I think, just to, sort of summarize it, he was talking about a very comprehensive approach, an approach where we are just not looking at the public sector doing it or the private sector doing it. That means basically getting all our resources in and seeing how best we can go ahead to address this. A lot of states have been thinking about this and probably are working towards something like this, and maybe southern states like Kerala and all probably have got ways in which they have tackled this. But my experience, as I was telling you, we've been in touch with the state of Odisha, and so we are actually coming up with a kind of a plan, like the state's plan for working together, where everybody comes together with a passion and just not from like a formal sense, to see how best they could work on what they're calling cancer control, both from the side of prevention, from the side of improving diagnosis, improving capacity for diagnosis, improving capacity for treatment, follow-up, and palliative care. And really looking forward, to see more such examples happen everywhere in the country.
Thank you, Dr. Prasad, for that. Also, I would like to thank all the panel members, Dr. Gaurav Agrawal, Dr. Prasad, and Ms. Urvashi, and also Dr. Bhavna, for joining us and discussing a very important point on how we can improve the universal health care and the various points we have spoken about. It is very interesting to listen, and we hope India is able to provide the best care for the breast cancer treatment here in India. Thank you so much for joining us today. I would like to welcome Dr. Asauri Sawant, my colleague. She would be taking over for the next panel discussion, and she would be discussing about expanding the opportunities for screening, a look at risk-adopted screening for relatives of patients with breast cancer. Over to you, Dr. Asauri. Thank you so much, everyone.
Thank you.
Thank you, Ms. Rithi. Thank you for that introduction, and thank you everybody for joining us so far. So just to summarize, today we are doing the Breast Cancer Action Day Summit sessions, and throughout the day you have seen deliberations on different topics related to breast cancer. In this session for today, which is organized by IHW Council along with Rapid Global Cancer Alliance, the topic for discussion is expanding the opportunities for screening, a look at risk-adapted screening for relatives of patients with breast cancer, powered by Novartis. I am Dr. Asavri Sawant, your moderator for today, public health specialist from Team IHW. And to discuss more in detail, we have some very eminent panelists here with us today. Let me start by introducing Dr. Vinod Sakaria, who is Principal Scientist, CSIR Institute of Genomics and Integrative Biology. Sir, we welcome you to the show.
Thank you very much.
We welcome Professor Dr. Somshekhar SP, who is Chairman of Medical Advisory Board at Aster DM Healthcare, GCC and India. He is the Global Director of Aster International Institute of Oncology, GCC and India, and also Consultant of Surgical and Gynecological Oncology and Robotic Surgeon at HIPEC and PIPAC Super Specialist. Sir, welcome. Thank you for joining.
Thank you. Thank you.
We also welcome Professor Dr. Hemant Malhotra, who is Professor and Head of Department of Medical Oncology at Shri Ram Cancer Center, Mahatma Gandhi College Hospital, Jaipur. Sir, welcome to the show. Thank you so much for joining. So you are on mute.
My apologies. I just wanted to thank you and my pleasure to be on board and hope to contribute. Thank you.
Thank you so much. We would have these panelists deliberating on the topic of expanding the opportunities for screening, a look at risk-adapted screening for relatives of patients with breast cancer. So as we all know that with breast cancer or cancer of any type, early detection is the key. Early screening, when done properly and at the right time, early at the stage, can go massively in reducing the risk of the intensity of breast cancer that people can get. So my first question is to Professor Dr. Somshekhar. Sir, a risk factor for the breast cancer that is non-modifiable is family history. The age of the individual, the kind and number of affected relatives, and the age at which the relative receives a diagnosis all impacts the relative's breast cancer risk. So to begin with, could you please elaborate on what risk-adapted screening is and how is it different from age-stratified screening? Could you please explain? Over to you.
Yeah, thank you. Thank you very much. You know, a country like ours, where there is no national cancer screening control program, because the most common cancer in India and worldwide is a breast cancer. A country like ours, we don't have a uniform compulsory breast cancer screening protocol. Now, a normal screening protocol is as per the international guideline, where a woman who is about 20 do breast self-examination every month. And after 40 to 50 years, she does a clinical breast examination twice a year and an annual mammogram. For a country like ours, where a woman is 1 decade young, dense breast, no availability of screening, mammogram, and reporting, this is not possible. So the difference between a conventional mass screening is every woman beyond a normal age, whether they have a risk or not, family history or not, FDR or SDR, that is a first degree family relative or second degree, undergo a uniform screening. Now, if you leave that aside, if you can't do that, or a country is doing that, but still you need to pick up, the risk assessment is you start the screening in a lady who has history of first degree relative, we call that FDR, or SDR, second degree relative, the age at which that relative would have a cumulative risk of having the cancer. Like for example, if a family member first degree in their family had a breast cancer, age less than 50 young, then at the age as early as 27, they reach a risk of 2.2% equivalent of a person who could get a breast cancer. Similarly, if the family has a second degree relative or a first degree relative beyond the age of 50, at the age of 37 itself, they reach the risk of them getting, cumulative risk of getting a breast cancer more than a general public. So when we see a risk-adapted screening, it is based on the family history, hereditary, and first degree or second degree, age at which their family had, and what age they are based. Then target them at that age ranging from 27 to 36 and start a screening for them so their life is preserved and we don't identify them at a higher risk. This is what we actually mean by that.
Thank you so much, Dr. Somshekhar. So just for clarification for our audience, can you please elaborate what would you mean by first degree and second degree relative?
Yes. See, now, suppose I'll take an index person. The first degree would be if mother, sister, or daughter, or father, sister, they are all first degree. So they're the first degree of the relative. So any of the first degree, invariably, they live in one nuclear family. The second degree would be an aunt, or, like you have on the father side or mother side, paternal or maternal side, who are not in the immediate gene carriers. That is, father, mother, parents, siblings fall into the first degree, sister, brothers. So if any of them are one generation beyond that are second degree. So second degree is a little less risk factor, but still very higher than the common public. So as per the current recommendation, one first degree less than 50 years, or two second degrees, or one second degree having a breast ovarian share the same risk of having breast cancer. They all fit into a prophylactic hereditary breast cancer screening of the gene and then starting an early screening for breast cancer.
Thank you so much, Dr. Somshekhar. So my next question would be to Dr. Vinod. Sir, although mammogram screenings have lowered the number of deaths from breast cancer, better screening methods could help determine the risk and help prevent cancer before it develops. So could you please elaborate further on the role and effectiveness of genetic screening tools for breast cancer risk and how that works? Over to you, sir.
Yeah, thank you very much. So when we talk about screening and very specifically in this matter, genetic screening of breast cancer, we need to understand a bit about the history of why it came and also look at the pros and cons and the evidence sort of supporting or not supporting such a screening approach. So the basis of the breast cancer screening comes from the fact that individuals who have a BRCA1 or BRCA2 positive in sense of pathogenic or likely pathogenic genetic variation would have a higher than normal lifetime risk of developing breast cancer. Now, does that mean that that is enough evidence to build a screening tool? Probably no, because if you look at the outcomes of such a screening, it's essentially whether you can prevent breast cancer from happening, whether you can decrease the mortality from happening, or you could treat breast cancer much more effectively. Unfortunately, there is no evidence to suggest that such a screening using genetic tools can improve the care, the mortality, or the treatment of individuals having such mutations in the general population. Now, does that mean that that is completely ineffective? The answer is probably no. In very specific situations, like for example, in specific communities where there is a higher than normal prevalence of BRCA1, BRCA2 mutations, the best examples globally are the Ashkenazi Jews, that's widely discussed and widely studied. But and also we do have such founder mutations in very small focused communities in the country for whom such a screening tool might be beneficial. But there is still no evidence, even in the Ashkenazi Jew population, that BRCA1, BRCA2 screening could actually improve the outcomes of the disease in terms of the mortality or the survival. So at this point in time, it is a screening tool that needs to be looked at in a very focused approach in a very small number of individuals. The other advantage of such a screening is also for individuals who might want to consider very specific therapies like the PARP inhibitors, which is very effective in BRCA1, BRCA2 mutation positive individuals. But other than that, in terms of a screening tool, it is probably not the right thing to do on a general scale. There are much better approaches to be used for screening individuals more than genetic, and it should be limited to only small focused subsets of individuals who might have even at least modest benefits from the screening. Thank you.
Thank you so much, Dr. Vinod. That explicitly answers our question. Moving on, my next question would be to Professor Hemant Malhotra. Sir, how can we improve the adherence to the recommendations for regular testing, especially among those with elevated risk of disease? As in previous sessions today, we saw that people are recommended to go for breast screening, but they are scared to follow it. So how can that adherence be improved? What measures can be taken? What would be your suggestions?
Thank you, Dr. Sawant. And I think, like my two previous speakers have elaborated on some of the aspects and the risk factors with Dr. Somshekhar, my very dear friend, which he elaborated. I'd like to add two more things to that. The first is that if a lady has bilateral breast cancer, then the first degree relatives and the second degree relatives of that patient are at exceptionally high risk. So that is another factor which we need to consider. And if a lady is BRCA1, BRCA2 positive done because of whatever reason, not very many patients in our country get it done, then again the family members of this particular individual need to really focus on those. Now, coming to your question, like how can we increase the net of looking for breast cancers in the family members of the patient? So I think the best time to counsel the patient and the patient's family is when the diagnosis is made. That is the time when they are the most receptive to your inputs regarding stuff for themselves and stuff for their families. So I think it is the duty of every oncologist and every surgeon who has a patient of breast cancer to counsel the patient, particularly if the patient is at high risk of a familial breast cancer. And those risk factors, clinical factors have already been highlighted by Dr. Somshekhar. Then it is the duty of the oncologist to counsel the patient that her relatives will be at significantly high risk of developing breast cancer, and appropriate screening modalities need to be instituted for the high-risk family members. So that is probably the best time to counsel the patient. So was this the question you wanted addressed?
Yes, sir, definitely. Thank you so much.
Thank you
for answering. So as all our speakers are mentioning, if you have family history, you need to get your breast screening done. It is absolutely must. Let us now look on to the different types of breast screening that you can go for. My question would be to Professor Somshekhar. Sir, what according to you is the best tool for getting breast screening done, regardless of having familial history of breast cancer or not? As we have seen, everybody emphasize that getting your breast health check once a lifetime is a must, and as you age, once every few years is recommended. So what tools of diagnosis would be best for when we are looking at such large population in India, such large numbers? How can we get that done? Over to you.
Thank you. There are two aspects: what is best and what should be done. What can be done, what should be done. Now, what is best is different, and for a mass screening, what is economically viable, reproducible, and adaptable. There's no use of having one of the fantastic machines sitting in a rocket on a moon if it cannot be covered to majority of the population. That may be the best, but that's not doable. So we need to strike a right balance where the sensitivity specificity means able to identify early cancers, cure them, balances with easy adaptability, applicable to mass, and easily reproducibility. Now, essentially for all the screening, not just risk group or anybody, there are following tools available. Breast self-examination by a lady herself, 5th day after her period stops. So the breast changes by the hormone stops. It is proved by, this is called a BSC. Breast self-examination is proved to reduce the death rate by 16.6% by this alone. Now we have CBE, that is called as clinical breast examination, not necessarily by cancer doctor, any healthcare worker. It could be a gynecologist, physician, trained ASHA workers, healthcare workers, by a clinical breast examination at least once in 2 years, or if possible once a year. This is proved in itself to reduce mortality, death rates by 28.8%. Now the other modality which is the best is combining a X-ray mammogram and a sonomammogram, ultrasound. So essentially the screening tool in general public is BSc, breast self-examination, clinical breast examination, and then a mammography and a ultrasound. There is one more tool called as MRI mammogram. Now remember, it is very important, breast self-examination, clinical breast is adaptable for a mass country like ours. Economical, cheap, easy. We already have a ICDS, that is a woman and child ASHA workers, who visit every home in village, taluk, PHC, who look care of the anemia in a woman, health and child. So a lady can easily be coupled to do a clinical breast examination, bring in awareness of breast self-examination. Easily doable, doesn't cost too much. Already we have a system where we can, piggyback that. Now, but the Western world calls a mammography. It is impossible in a country like India. Why? We have a woman who are 1 decade early. India is a hub for largest young women with breast cancer, unfortunately. We have young population. In Indian woman breast cancer is 1 decade early. X-ray mammogram in a young woman under 40 or under 50 with a dense breast is not a very good tool. You need to do clinical breast examination and a ultrasound. So that's why, unfortunately, mammogram is not a good tool for a country like ours. Now, there is a little difference for a woman who is a BRCA1, BRCA2, where there is a genetic predisposition of hereditary breast cancer syndrome or a high risk group. This is the only group where BRCA1, BRCA2 is positive. They're young woman, bilateral. There is a special unique called as triple negative cancer. Usually, mammogram X-ray is not recommended. Number one, it may not pick up. Safety of X-ray mammogram in this people who have a mutation already is not very proved. So that is the only place the international guideline recommends MR. MRI is impossible in a country. The cost of one MRI is 2 breast cancer women in a government setup can be treated. So these are the tools available. For a proved gene positive, the recommendation is clinical breast examination, ultrasound of the breast, sonomammogram 6 monthly, once a year MRI mammogram, very difficult. Focus group of 10%. In all other population, mandatory breast self-examination, clinical breast examination, at least once in 3 years, if possible, have a X-ray mammogram and a sono. So this is the statistics evidence-based as per the study, and the Swedish trial, a large trial which looked into this, showed the benefit of these in saving a woman's life, identify the cancer early.
Thank you so much, Dr. Somshekhar. That was so explicitly explained. And I'm sure the audience listening to us are also understanding what to do, at what age to do when you have family history of breast cancer or not. So thank you so much. My next question would be to Dr. Vinod. Sir, understanding a patient's genetic pedigree pattern of inheritance and predisposition can help identifying patients and their family members who carry a gene mutation associated with an increased risk of breast cancer. So could you please elaborate on the several risk models that are available that can help determine the probability for developing breast cancer over a given time period, or the risk of having an inherited mutation in a known high-risk gene? Over to you, sir.
Right, thank you. So the basis of all cancer risk prediction models is the idea that you can use a number of factors. This could be as simple as the age, the parity, the age of menarche, so on and so forth, to be able to provide an individualized risk over time for developing breast cancer, right? So this is essentially built for use by non-experts, where you can factor in a number of parameters and be able to provide a risk assessment for a general population. Now, why do you need to do a risk assessment? There are multiple reasons why you need to do that, and there are multiple endpoints why you need to do that. The first is, of course, in a non-expert situation, whom to refer to a tertiary care center. Second, whom to put into a high risk for preemptive screening. Third, whom do you want to prioritize for example, chemoprevention? And fourth, whom you would want to send for a BRCA1, BRCA2, or for that matter, a genetic panel screening. Now, the endpoints could be very different for each of them. Now, there are a subset of such tools which can also factor in the genetic mutations into the prediction model. But one thing you need to keep in mind is that even when you screen BRCA1, BRCA2, the general prevalence or the population prevalence of BRCA1, BRCA2 mutation is approximately around 2 to 3 per 1,000 individuals. It's not a very common thing to have BRCA1, BRCA2 positivity, except, like I said previously, in very small subgroups or endogamous communities where there are founder mutations which are very prevalent. But generally in the population, you should not expect more than 2 to 3 individuals who are likely to be BRCA1, BRCA2 positive. Now, the idea of all of this is to be able to add more parameters, and genetic being one additional parameter, which can provide some increased accuracy or discriminating ability in our ability to predict risk for an individual. But having said that, we should also keep in mind is that none of these risk prediction models are very accurate. Second, they are very different in different ethnic groups. So a risk prediction model in one ethnic group may not be transferable to another ethnic group. Third, the BRCA1, BRCA2 mutations and their positivity could also be widely different between ethnic groups, which is very well documented. And therefore, also the risk of developing cancer could be different in different ethnic groups. So what I'm trying to highlight here is that while genetics could form a minor component of the risk prediction models, one, they are not very accurate for wide use. Modestly speaking, their area under the curve for discrimination is around not more than 75%. Nevertheless, they are useful in some communities in high-risk individuals to be able to do, who are amenable to genetic screening, and therefore might be useful in a modest effect.
Thank you, Dr. Vinod. So my next question would be to Professor Hemant Malhotra. Sir, what are some of the potentially feasible and effective approaches for identifying breast cancer survivors who are at high risk or are in the vulnerable groups? How can we know so that we can get their relatives screened as early as possible? Over to you, sir.
Thank you, Dr. Sawant. And I think one scenario I've already highlighted is that when the patient is first diagnosed, and that is the best time to counsel the patient, not only for herself and the treatment for her disease, but also to counsel her that her family members might be at increased risk, and that that message should go to the family members also. Being in oncology for more than 30 years now, and as was highlighted by Dr. Somsekhar and Dr. Vinod, both of them, there is no way that we can reach and do or have a screening program for every single woman in this country. And there are several reasons for that, reasons of literacy, reasons of non-availability of mammograms, non-availability of people to read them, the non-availability of the infrastructure to refer once a suspicious diagnosis is made. So I have 2-3 situations in mind. One is when a patient of breast cancer is diagnosed. The second is, I think we need to counsel and train our gynecologists that every time the patient goes to the gynecologist, whether a family history of breast cancer is present or not, as a part of the gynae examination or as a part of the obstetric examination, the gynecologist should also do a bilateral breast examination. So that would, be a simple technique to at least have a clinical breast examination for a significant majority of women, particularly who are at risk of breast cancer. And then I think the second important thing which I've seen over several years is that once a lump is detected by herself or by a peripheral health worker, then there should be a foolproof track of taking care of that lump, making sure that it is not malignant. And if it is malignant, then making sure that the appropriate treatment is given. I mean, there can be nothing worse than having a screening for high-risk patients, finding a lump, and then not being able to address that lump. That is a situation which should not happen. And the track of taking a suspicious lump forward to the logical conclusion must be in place before any such activity is begun. Thank you.
Thank you so much, Professor. So let us now look on to the different opportunities for screening in future breast health as well. My question would be to Dr. Somshekhar. Sir, we are looking at the expanding opportunities for screening. So what, according to you, would be, the screening methodologies of future, the advanced techniques that maybe we are practicing from now, but would go on in future, and some techniques that we would stop using are not as effective? So what, according to you, would be that? Would that involve risk-adapted screening? How? Why not? Over to you, sir.
Okay, there are two things. Number one, what is the methodology we can adapt with the existing screening tools? That's point number one. Second thing is there a new tools which we can adapt which we are not able to currently use? So I'll answer the first one. For a country like India, opportunity screening, risk adaptation, we should definitely do. Opportunity screening is a woman is already come to an hospital for a lump, pain, or some cyst, some breast related problem, not necessarily cancer, or a woman has accompanied a relative or a family member or neighbor for a breast lump. So then they are already in hospital. They have made that effort to come down. Just clinically examine them through a gynecologist tube and do this one. So we have to adopt opportunity screening. In fact, unfortunately, in India, that is the most common way of screening, which is very sad. Second, risk adapted, very important. For that, we need to maintain a national cancer hereditary risk registry. Professor Dr. Rajkumar, who was a scientist in Adayar Chennai Cancer Hospital, maintained for a long time this hereditary high-risk cancer registry. Now Tata Hospital also maintains, and there is a part of National Cancer Registry also trying to maintain. If you know that, then you will know the burden. In the Western world, this high risk based on the risk factor is 10 to 15%. But there was a paper which, me and Hemant Malhotra sir and many of us authored. We unfortunately found in Indian cohort it was as high as 25 to 30%. So we'll not get a good picture. So what new tools we have to, new models we have to use? Opportunity screening, risk adaptation, definitely yes. And clinical breast examination as per the study published from Tata Cancer Hospital, which was done in Maharashtra, rural area and everywhere. Just one clinical examination once in 3 years saved more than 20-30% of lives. So these three for a country like us, with the existing screening tool, yes. Now, what are the new screening tools that are coming, which we are part of research and many people are part of research? Number one is based on a thermography. So because, you just go and set it up in a place and look at the image based on the heat infrared, which is easily reproducible. But the technology needs to be refined, validated, cost of the machine bulkiness needs to come down. Second, a simple blood test. Because people in India love these blood tests. Because during COVID, you see how people got all the swab tests and RT-PCR. Now there is a lot of renowned effort that has come down in the world on a circulating tumor cell antigen antibody based on a simple blood test which can detect a cervical cancer, breast cancer. But I have to confess, as of today, it is still not gone beyond a high-level evidence. It is a small cluster of studies going, very promising from US and also happening in India. If that screening tool comes up, then you're not dependent on X-ray, power, radiologist to read, cost, machine don't have to go. Just do a screening, come back to central. It is proved that if you screen 1,000 women, 2 would have a breast cancer. In a country of 1.4 billion, 60 to 70% young population, 45 to 50% women, 45 to 50% women. Imagine how many people you have to screen then. So the new screening, which is promising, I believe, is antigen antibody based simple blood test to come. If that happens, probably if we develop an Indian, like, we have developed an Indian vaccine for HPV, for cervical cancer at 1/10 the cost now. So we can be the model because we are the hub of genetic and innovation and do it. So I can put it these two way, methodology with existing, new methodologies which are already there, which needs to be tried in mass.
Thank you, Dr. Somsekhar, for enlightening us with newer technologies as well as the existing ones. Definitely, it is very nice to know that these technologies that are being researched, the thermography as well as antigen antibody blood testing methods, are being tested for future breast cancer detection. And if they are successful, it would open up a whole world of new opportunities and make things so much easier for us. And with the existing history, we have seen India to become so successful in producing fast, rapid results through our COVID experience. So I am sure this would also help in mass breast cancer detection in future, if realized. Moving on to Dr. Vinod next. Sir, coming back to what we were discussing with you, for patients who undergo genetic testing, expertise is required to ensure that the appropriate testing is ordered, that it will be adequately interpreted, and that the results are likely to influence management of the patient or family member at risk for hereditary cancer. How equipped do you feel India is to manage such kind of testing? What would be your comments?
Thank you very much. So when you do a genetic screen or a genetic test for that matter, there are different labs across the country which do different kinds of tests and interpret in different ways. And that is why you need to have a global consensus on what to call a pathogenic variant and what to call a benign variant. And fortunately for hereditary breast and ovarian cancers, there has been a consensus available, which is widely known as the American College of Medical Genetics and Association for Molecular Pathogenesis joint guidelines on interpreting the pathogenicity of variants. Now, unfortunately, while globally in the biggest economies, whether it is in the US or in the UK, Europe, there have been consensus guidelines followed for interpretation of genetic variants. Unfortunately, most of the testing laboratories do not strictly follow these guidelines, while most of them rely upon databases which are either developed from a different ethnicity or from a different population. Now, this is one area which needs a lot of work to be done in the country, also because soon with the large population that we have, soon we might actually end up doing the largest numbers of BRCA1, BRCA2 tests globally. Now, what is really required here is essentially a framework where people could collaborate with each other and share the data, and people who could now provide the consensus annotations or the consensus interpretation for each of these variants so that they can be widely used, rechecked, and be used for clinical reporting of patients. Unfortunately, very recently, we have put together one such framework, which is called the BRCA Indica, which is widely supported and collaborated upon by a number of medical oncologists. And in a short while, we could put together around 10,000 odd genetic mutations, including the very prevalent ones in the country. And we provide the joint guideline-based annotations freely available to all the contributors. We only hope that this could be much better in the coming days. The other gap that we have is in the availability of tests and accessibility of tests. And that's largely because BRCA1, BRCA2 screening has been a very expensive proposition. It is not widely available and quite expensive for a common man to afford it. And that is also another area which requires a lot of input to make such tests widely accessible and also very cost effective, so that the poorest of the poor can actually access this test like any other biochemical test out there. So I think that's all the 2 points that I have to make. Thank you very much.
Thank you so much, Dr. Vinod. So we saw our esteemed panelists, Dr. Vinod and Dr. Somshekhar and Dr. Hemant, talk about the benefits of this new technology, which is risk-adapted screening for relatives in detail. Sir, my question to Dr. Hemant would be, sir, what are the limitations of risk-adapted screening that you see, and how can we fulfill those gaps that you see that are there still in breast cancer detection through risk-adapted methods?
So I think before I answer your question, Dr. Sawant, let me just add on to what Dr. Vinod said. Before you order a genetic test on a patient, you have to counsel that patient. Like pre-test counseling is as important as just ordering a test. It is not that you write on a slip of paper, advise BRCA1, BRCA2, or advise familial genetic cancer testing. You have to counsel the patient. You have to tell the patient what to expect, and you have to talk about variation of unknown significance, because so many times the patient will come back and tell you, you've spent 60,000 rupees of mine, man, you don't know what to do. My personal feeling is that we should have a medical geneticist in all large cancer hospitals, at least, or in those hospitals where we don't have a geneticist, we should have the oncologists trained in genetic counseling, and then only you should, order the test. Ordering the test is very simple, but the implications and ramifications of the report can have very deep psychological implications. For a patient, if you ask for a test and she is BRCA1 positive or BRCA2 positive and she has a 16-year-old daughter, then all those questions come up and you have to be ready to field those questions. So I think that is very, very vital that you very carefully counsel the patient before you order a test. It is much more complex and complicated than asking for another cancer related test, say like a PET CT scan, all the ramifications of that, but there are step 1, step 2, step 3 ramifications of a genetic test, and that has to be counseled. So I cannot overemphasize on the need for the oncologist knowing about the various ramifications and counseling the patient and the patient's relative before ordering a test. Secondly, we did publish a consensus statement from our country. Dr. Somshekhar was part of that group. I was the lead author of that. We published it about 3 years back in the Journal of Global Oncology. And we are in the process of revising that. Dr. Rajkumar, Dr. Rajiv Sareen, Dr. Sudeep Gupta, Dr. Raja Pramik from AIMS Delhi, the top people who run breast cancer familial clinics in our country are all part of the people who are writing this document. And in maybe a couple of months' time, we should have a revised, updated document available and accessible to most oncologists to refer to. Now, your question, what are the limitations of focused screening? Again, I think the most important limitation is that many times the patients don't listen to your advice. So in addition to just counseling, you have to spend some time and effort on educating the masses, educating the general public as to the inherited or the heritable aspects of breast cancer, so that they themselves come forward. Okay, my Masi had breast cancer. I would like to get myself tested. We have to try and get to that point. And then, as I said earlier, every point of contact with the patient can have when she's coming to the hospital, while waiting in the clinic or while visiting the gynecologist, related to obstetrics or related to gynecology, that might be the right time to do a clinical breast examination for the lady. Again, my feeling and consolidated over 30 years is that we just cannot mass screen, at least now, all the women in the country. So we have to concentrate on focus screening. And these are 2 or 3 situations which has been already talked about by the panelists where we should focus on. Thank you.
Thank you so much, Professor. So, sir, on the same note, there's another question for you, which is, how is quality of life for cancer survivor dependent on early screening? Another question that I had in my, I wanted to ask is that this topic of National Cancer Hereditary Registry was brought up, and how can this play up for for explaining it to our viewers? How can this be advantageous in the future for early detection of breast cancers and all different kinds of cancers?
So let me answer your second question first. Like all of us have patients, large number of patients, but our data keeping and data compiling and data consolidation, we are a little weak on that front. So if we have a national initiative which pools data from high volume cancer centers and busy oncologists, then you have something, some Indian data is available. We know that our phenotype is different from the phenotype of a European or the phenotype of a Japanese. And I have no doubt in my mind that our genotype is also different. And once we know our own genes and the implication of those genes, maybe there is a variation of unknown significance in the West. And if we have enough number of data that particular VOS has a pathogenic significance in our country, we will only be able to find out and detect if we have our own database. So I think this is a really good initiative, and each oncologist who sees breast cancer patients should contribute to this. Now, what was your first question? Can you come again?
So my first question is, how is quality of life for cancer survivor dependent on early screening? What sort of implications, mental, physical, and emotional, they go through while they are given this detection result that, okay, you have this breast cancer now? So what how is their quality of life affected, and how can we work towards improving that so that this doesn't come as a shock to them, just another some disease, which is reassuring that you would be able to treat it provided you get good treatment?
So I think oncology outcomes and cosmetic outcomes, which are very, very important for the patient, are dependent on how large the tumor patient has, what is the stage of the disease. Now, if we can diagnose all our ladies in stage 1, which should be our endeavor, then we have minimal surgery, breast conserving surgery, extremely good cosmesis, possibly no chemotherapy, possibly no radiation therapy. So that is a huge, huge advantage as compared to a patient who has stage 3 breast cancer, in which you have to give neoadjuvant chemotherapy. Then you may not be able to do breast conserving surgery. You'll have to do removal of the whole breast. And then you will also have to give post-operative adjuvant radiotherapy, and all the consequences of that, the chest wall burn, the cardiac toxicity, the pulmonary toxicity, the lymphedema. So I think there are huge advantages to diagnosing the patient in stage 1 as compared to diagnosing the patient in stage 3. And that should be our endeavor, that we downstage and stage migrate the disease in a downward fashion in our country. Let us not, at least in the first stage and at least in the present time, try to diagnose patients pre-stage 1, which happens in the Western countries. But let us make sure that every single patient does not cross stage 1, 2, and is diagnosed before crossing stage 2. And in the next few years, with your efforts and our efforts, we don't see any patients with stage 3 and of course with stage 4 breast cancer. Thank you.
Thank you so much, Professor. So this next question is directed towards Dr. Vinod, but it is again open for anybody to answer, which is currently genetic testing in India for early screening doesn't have very high uptake as we see in the studies. So how can we improve that? What measures can government take and doctors take in this regard to improve the uptake of genetic testing for in breast cancer screening, early screening?
Yeah, so thank you very much. As I earlier stated, that wide genetic screening for everybody is something that is not to be propagated. Genetic screening is useful for only a very small subset of individuals who could be risk assessed based on one of the guidelines available. So even for this small percentage of individuals who could get a breast cancer genetic screen, you are really right that the uptake is quite small. And there are three aspects to this. The one and the most important aspect is that these are extremely costly genetic tests, and therefore most of the patients cannot afford it. Second, even if you do a genetic test, a significant large number of tests cannot be interpreted appropriately because they end up being a variant of uncertain significance or a VUS, which pretty much nothing can be done for lack of evidence or for lack of consensus. And the third and most important thing is that a significant large number of individuals, including clinicians, are not really aware about the availability of these tests across different hospitals. So putting together, I think that there needs to be a concerted evidence in what needs to be referred for a genetic test. Appropriate referral is very important. Second, interpretation and knowledge about how to go about interpreting the genetic test is also as important. And third and most important point is also that once you have received the genetic report, it's also as important to be able to counsel the patient appropriately. And we do have a depth of individuals who can appropriately counsel individuals. And this is a class of individuals who we call as genetic counselors, who are aware about the technology, who are aware about how to go about interpreting, and could touch base with the patient on informing the patient on the pros and cons of the test before the test, and after the report is done, what are the implications of the test.
Thank you so much, Dr. Vinod. So that comes to we come to the end of this session today. The entire Breast Cancer Action Day Summit we had today was full of insightful information on different aspects related to breast cancer. We had amazing speakers, very eminent people talking about and propagating the idea of early detection, early screening, so that we can help screen as many people all across the country as possible. So thank you so much. I would like to thank Professor Dr. Somshekhar, Dr. Vinod Sakaria, and Professor Dr. Hemant Malhotra for taking out their valuable time for being with us today. Before we close off this session, our panelists, I would like to request the end notes on Breast Cancer Action Day Summit. So if you have one advice to share with the audience, what would that be? It could be any advice for either breast cancer survivors or people going through this disease or the relatives of people with breast cancer. What would be your one advice? Let's start with Dr. Vinod. So.
Thanks. So if I were to have just one word of advice, I would suggest that follow evidence and create evidence so that practice and care can be better.
Thank you so much, sir. Professor Hemant, sir, your advice.
So my advice to the masses would be cancer is curable if diagnosed early. Don't be afraid. Go ahead and get it done and fight on regardless.
Thank you so much, sir. Spot on. And I believe if there is one key takeaway that you all can take from this session would be to never lose hope. Keep yourself informed, follow good evidence, and validate your sources, and also consult specialists for final advice. So with that, we end this super informative session on expanding the opportunities for screening, a look at risk-adapted screening for relatives of patients with breast cancer. I also close off with saying that, stay healthy, stay happy, and keep yourself informed. Thank you so much. Have a nice day.
Thank you, Dr. Sawant. Thank you.
Thank you very much.